my outline will be the definition of nocturnal hypertension, the components and pathophysiology, diagnosis, management, and conclusion. You know, nocturnal hypertension is a very important risk factor for cardiovascular and cerebrovascular disease. With the widespread use of ambulatory blood pressure monitor, I thank the previous speaker who spoke on ABBM, the diagnosis of nocturnal hypertension has increased. It causes target organ damage. It's always prudent and nice to record nighttime BP for all hypertensive patients, especially in diabetes. The definition in the European guideline, systolic blood pressure more than 120 and diastolic more than 70 is defined as nocturnal hypertension. Whereas according to the American guidelines, the systolic blood pressure is 110 and the diastolic is 65. Isolated nocturnal hypertension considers the daytime BP is normal, that is less than 135/85. The components of nocturnal hypertension, the previous speaker was talking about dippers, non-dippers. The number of nighttime BP measurement usually in the ABBM more than 6. In healthy subjects, nighttime BP decreased by 10 to 20%. The following 4 categories we say: extreme dippers is more than 20%, dipper is 20 to 10%, non-dipper is 10%, riser is 0 and above. Nocturnal hypertension is usually connected with non-dipping and reverse dipping. However, it could be excluded in dippers. It cannot be excluded in dippers. It is very rare among extreme dippers. This classification is based on ABBM. And you see the normal ABBM. This is the dipper, more than 10%, and this is the morning surge. And this is a very important slide. You can see the nighttime dipping depends on salt sensitivity, and it can alter in CKD, CHF, diabetes, structural vascular disease, insomnia. Again, the nighttime surge, just like morning surge, again nighttime surge is triggered by OSA, arousal, REM sleep, rapid eye movement sleep, nocturia. And the morning surge, again triggered by cold, exercise, worksite stress, smoking, alcohol, insomnia, and sleep apnea. Now the pathophysiology of nocturnal hypertension. The sympathovagal imbalance due to impaired baroreflex, diabetes, obesity, metabolic syndrome, leptin resistance, pre-existing cerebrovascular disease, orthostatic hypotension, working stress, Parkinson's disease, neurodegenerative disease. Of course, disrupted circadian rhythm, the circadian clock gene abnormalities, BMAL1 and NPAS2, and then volume retention, very important, salt sensitivity, chronic kidney disease, insulin resistance, obesity, heart failure, and aldosterone increased, hyperaldosteronism, can cause volume retention. So one is sympathovagal imbalance, volume retention, and disturbed breathing, especially sleep apnea. I already told you disturbed circadian rhythm, and others like insomnia, depression, nocturia, nighttime activity, daytime activity shift, low socio-economic position, endothelial dysfunction, nitric oxide, and then work shift. This is the mechanism of effects of nocturnal hypertension, which produces cardiovascular disease. As you see, salt sensitivity increases circulating volume, especially when you lie down in supine position, the fluid circulating volume is more. The nocturnal increase in circulating volume also causes nocturnal hypertension. It leads to vascular damage. That vascular damage produces baroreflex depression and nighttime BP surge, and that triggers stroke, MI, and vascular dementia. The LV after load also increases nighttime because of the overload volume. LV wall stress leads to heart failure. Again, through kidney, intraglomerular pressure is increased, hyperfiltration is increased, and kidney injury. And these are the associated conditions in nocturnal hypertension, like aging, obesity, hypertension. Especially Asians are very prone to get nocturnal hypertension because they are always salt sensitive. And stress, diabetes mellitus, then orthostatic hypotension. Secondary hypertension also causes like obstructive sleep apnea, endocrine disease like primary aldosteronism, and the diseases associated are heart failure, CNS disease, restless leg syndrome, Environmental, you must always, summer, it's known to have nocturnal hypertension. Behavioral factors like high salt intake, reduced physical activity, poor sleep quality, nocturia, and shift working. Of course, I've already told you about that. Now, how to diagnose nocturnal hypertension? It's very clear that nocturnal hypertension could be diagnosed only by BP monitoring. Of course, there are two possibilities. One is ambulatory BP monitoring, other one is home BP monitoring. So some of you may wonder how home BP monitor has a role in the nocturnal hypertension. Even though ambulatory BP monitoring provides more measurements and therefore should be more accurate than home BP, Cario et al. Showed systolic BP obtained by home BP monitoring was a good predictor of cardiovascular events, independent of in-office and morning in-home systolic blood pressure measurement. Home BP monitoring, in this particular equipment, they measure nocturnal BP 2 a.m., 3 a.m. and 4 a.m. This special type of home BP monitoring could have the potential to be an alternative to ABBM for the measurement of nocturnal hypertension. They proved this is as good as ABBM. And this is very important. This is the lot of research is going on the home BP monitor, how to measure nocturnal hypertension. Using the Medinote, they did the first study, JHOP study in Japan. Then the second one is ICT-based information communication technology. It plays a very important role in latest cardiovascular medicine. The ICT-based nighttime home BP telemonitoring device. They did a study, Nocturnal study. I will talk to you in the later. Trigger nighttime HPBM, TNP. You must remember this term, TNP is trigger nighttime HPBM. Hypoxia can trigger, heart rate can trigger, low heart rate and hypoxia can trigger BP surge in the night time. So actually WASP trial, they've done this trigger nighttime BP, TNP. Then again, ICT based TNP, this is called INTP for night by night evaluation. Then another interesting thing is wearable beat to beat continuous surge BP monitoring. We call it as WSP. Again, this WSP and the trigger nighttime combined technology has come. So there are so many technologies in the home BP monitor to detect the nocturnal hypertension. This is the night view blood pressure monitor by Omron. And hypoxia trigger nocturnal BP monitor, I have told you, with a preset threshold for oxygen desaturation, which is continuously monitored by pulse oximeter. The HPBM device is triggered to initiate BP measurements when the wearer's oxygen desaturation falls below threshold. So this is the principle of trigger BP monitor. Whenever there is hypoxia during sleep apnea, it triggers the BP surge is there. In a normal ABBM also, you may not find this particular point. That's why these hypoxic triggered monitors are sometimes better than APBM. And again, like hypoxia, the lowest heart rate trigger function to TNP to detect the basal nighttime BP when the sympathetic tonus and the BP level and the BP variability are at a minimum during slow wave sleep. So normally it is low. Slow wave sleep during nighttime, sympathetic tone is less, but this heart rate less triggers this and we can find out through the machine. So this is the figure. We can see BP surge due to hypoxia. Again, there is another thing called ICT based TNP. I have told you, INT system for night by night evaluation. The repeated assessment enabled the detection of day by day variabilities in nighttime BP profiles which have been affected by the daily OSA severity and sleep quality during sleep as well as by daily behavioral changes like salt and alcohol intake at dinner, bedtime, sleep time, awakening time, nocturia and environmental factors, temperature, elimination, atmospheric pressure in the bedroom. And this is the spread device which can find out ICT based trigger nocturnal home BP. And then I told you wearable beat by beat continuous surge monitor. This device is successfully detecting 3 nighttime BP surges triggered by 1 rapidly eye movement sleep, 2 arousal sleep, 3 OSA episode. And this is the WSP tonometry type of BP monitor, home BP monitor, which is very, very useful and it's now going to be in the market soon. Management of nocturnal hypertension. According to the guideline, the first target of the treatment is control the morning hypertension. Second goal is uncontrolled nocturnal hypertension with a mask. Lifestyle changes are very important. To modulate the circadian clock system becomes a potential target for establishing novel prevention or treatment strategies for hypertension. Perturbation of the circadian clock is associated with behavioral aberrations such as short sleep duration, shift work, hectic lifestyle, and sleep apnea. Therefore, the improvement of the daily routine is a fundamental component in avoiding compromise in the circadian clock. And then now various treatment modalities are there. First is salt restriction, diuretic, angiotensin converting enzyme inhibitor with the combination of calcium channel blocker. Even sacrobutyl valsartan combination are being tried. Now people are trying a lot of combinations. Even valsartan, cilindapine combination they have tried. They also tried carvedilol, nifedipine. So many drugs they have tried. And now the newer things like if there is insomnia, you give melatonin or melatonin receptor agonist, orexin receptor blocker. A significant benefit of beta blocker in nocturnal hypertension has not been demonstrated. But taking drugs in the night is comparatively better, they say, especially combination therapy in the night. And then baroreflex activation, renal denervation are being tried for nocturnal hypertension. And this is the picture. Step 1, you target first for the morning BP. The second one, control the circulating volume by salt restriction, diuretic, MR blocker, SGLT, and sacrobutyl valsartan. Vascular disease, calcium channel blocker. In OSA, sympathetic activity, CPAP, sympatholytics, renal denervation, and melatonin, I already told you. And this is the newer modalities, which is renal denervation, sodium glucose transport inhibitor, mineralocorticoid receptor blocker. So there are a lot of studies on SGLT, RNA inhibitor, MR antagonist again, and these are the various trials which I've talked to you, where they use the home blood pressure monitoring, the newer ones, and with the drugs. And so many combinations they have tried, as I said, cilindapine, valsartan, and then valsartan with hydrochlorothiazide, and then carvedilol, etc. So this is the management of nocturnal hypertension, ICT-based, high salt sensitivity, optimal BP monitoring, clinical trial data, race and genetic characteristics. Especially Asians, this is the thing. I conclude, the current direction in the management of hypertension is towards earlier and lower BP control for 24 hours, including the nocturnal and morning periods. The nighttime BP management is especially important to prevent cardiovascular events, especially heart failure, vascular damage, as well as age-related organ damages such as CKD, cognitive dysfunction. Nighttime home BP monitoring is expected to be introduced in clinical practice. In the near future, ICT-based anticipation medicine that predicts future BP levels will contribute to the target of zero cardiovascular events. For the precise anticipation of risk, the repeated measurement of individual time series, big data will be essential. Research and development into new HBBM devices with less consciousness of BP measurement and evidence of the efficacy of the home BP telemedicine and telecare in consideration of nighttime BP are also needed. So ladies and gentlemen, I think Stokalingam is going to talk about mind and heart. Controlled diet, takes regular exercise, has time to relax, does the right toil and discharge of his duties, observes proper hours of sleep and awakening, and is balanced in his actions and reactions, emotions and reactions, duties and rewards, conquers his disease, says Bhagavad Gita. Thank you very much.